you feel moved to contribute to ongoing efforts to research eosinophilic GI diseases. Thank you for your generosity. I'm certainly indebted to my co-authors and collaborators who are listed here, as well as vital research funding that has made prior and current work possible. Thank you for the support from CEGIR as a Dr. Hirano scholar. And as you can imagine, research funding provides crucial resources to pursue clinically relevant questions and discoveries that aim to improve the well-being of our patients. So thank you again.
Thank you so much. We have some questions. Sorry to go beyond scope of your work. Do you know if dupilumab results are similar in adults?
If you're referring to the autoimmune manifestations, we actually know more about those in the adult population. So there have been reports of psoriasis and inflammatory arthritis in the adult population, depending on what articles you read about, reported up to about 5% or so. But thankfully, most of these manifestations are mild. They can be treated with medications, like for psoriasis with topical medications, or for mild arthritis with NSAIDs. And certainly if they do have severe symptoms, then dupilumab would have to be stopped and they would have to treat accordingly.
Thank you. I don't see any other questions. If people would like to put them in the chat, Shay, do you want to go ahead with the question for Dr. Abonia?
Yes. Dr. Abonia, we had a couple of questions. You mentioned scar tissue on the back. Although they're not hypermobile, should there be concerns with scar tissue on the back?
It wasn't so much a scar tissue on the back that you were seeing as much as it was a stretch mark. And what ends up happening in that case, in that particular case, that individual was simply growing so quickly that they started getting horizontal lines across their back. It is not, while not visually pleasant as far as patient is feeling about it, it is not necessarily something that can lead to long-term disability or things of that nature in most cases of patients who have these kinds of problems. And you start thinking about those kinds of problems with more severe forms of disease, meaning things like the Loeys-Dietz syndrome or Marfan syndrome, things of that nature for the most part.
Is hypermobility associated with levels of EOE? For instance, someone who is very hypermobile, do they have more acute EOE?
Not necessarily. You can definitely get patients who have very, very severe disease and have no evidence of hypermobility, and vice versa, very severe disease with evidence of hypermobility. And I can't say that the degree of hypermobility is clearly associated with degree of disease, is what I would say.
Okay. The next question is why does many patients report significant weight gain with Dupixent use with no diet or exercise change, and yet it's not a reportable side effect?
I think that weight gain, I know that's been anecdotally reported, but I don't think to a degree enough to be included in the category of other side effects, such as the skin side effects and the ocular side effects. So certainly if that is a concern that you have, I would urge anybody to on dupilumab to speak with their primary care provider, or with the prescribing provider rather.
Is there any data on starting Dupixent when kids are really young and having EOE reversed or undetectable after they've been on the Dupixent?
So we do know that dupilumab has been approved for age 1 and up, and can be quite effective in essentially fully controlling the disease. But we'll have to continue to monitor how these children do over time on dupilumab, as it was just recently approved.
Is there any research on food avoidance causing anaphylaxis to patients?
So in the context of EOE, if there are certain foods that are excluded for a long time, you know, from a oral tolerance perspective, if your immune system is not seeing a food for a really long time, then there is a theoretical risk of developing an anaphylactic or IgE-mediated food allergy to that food. I don't know that we have rigorous, you know, data showing prevalences of those, but that is why it is useful to have that conversation with your allergist, if this applies to you, about whether there's a need to do allergy testing if a certain food was not included in the diet for a really long time, and then is being added back because maybe they're being treated with a medication and now you're liberalizing the diet. Yeah.
Is there any data on starting Dupixent when kids are really young and have EOE reversed or undetectable?
I think we addressed that question. Again, dupilumab approved in 2024 for age 1 and up, and can be certainly quite effective, but we'll have to monitor longitudinally for you know, for the time to come.
Okay, thank you, everyone. Now next, our next speaker is going to be Dr. Josh Wechsler. He is the medical director of the Eosinophilic Gastrointestinal Disease Program at Lurie's Children's and a Cured Foundation research scholar and a previous CEGIR scholar. He is also the principal investigator, and he is also a head of the Wechsler Cured Lab. And he's going to talk to us tonight about mast cell.
I'm looking for the shared link to be able to share my slides.
Right in the center.
Oh, there it is. Ah, oh, geez. Rookie
Sorry.
mistake. No, my own fault. So, all good. I am delighted to talk to you today about mast cells. Absolutely one of my favorite topics. I've been involved in the mast cell field since, frankly, I was a fellow. So I've experienced all different shades of it, not just even in EGIDs, but in inflammatory bowel disease as well. It is a mysterious cell, no question. I'm going to talk to you a little bit about why it's so mysterious and what we know and, you know, frankly, what we don't know. So just an initial slide on my disclosures. I'm not really going to discuss anything except for a drug related to the company's Celldex. So really, I like to start with why are mast cells ignored? Because I think this plagues patients, frankly. And it's for a number of reasons. So one of the reasons why mast cells are ignored is that they require a special stain to visualize them. And as a consequence of this specialized stain that's required, they're very hard to identify. And so it takes a lot of work to actually just find them. You can see a piece of tissue on the left, nothing visible, and then you stain for them on the right, and oh, there they are, tons of them. So just very, very, very hard to appreciate. Another reason they're ignored, there's no consensus on how we actually identify them. You can see on the left, tryptase staining looks very distinct from CD117, KIT staining on the right. The tryptase staining is a granule stain. It'll stain both in and outside the cell because the granules get released. CD117, it's a surface receptor, but it's expressed by other cells. So when you look at CD117 counts compared to tryptase counts, they're a lot higher. So as a consequence, we don't have a consensus on that. In addition, they look all sorts of different shapes. And which mast cells do we count? You can see one that's nice and rounded, A. You can see that little sliver in B. You can see a bunch that are clustered together. How many do we count? All these little granules, is that actually a cell? And it gets very, very, very confusing. Now, how many are even normal? Still up for debate. You can see on the left here a study that's looked at this number, at least from the perspective of CD117. In the esophagus, very few actually. You really shouldn't have very many mast cells at baseline. That's what we found as well. But they're way more common throughout the rest of the GI tract, you can appreciate. And then on the right, a paper that I put together with Robert Genta and Evan Dellin and a number of others, really looking at healthy individuals and different stains and all sorts of numbers describing the number of mast cells that are normal. So again, we don't really have a good handle on what's normal. And that's probably because we don't necessarily put scopes into healthy adults very much, and certainly not into healthy kids. But we have, at least working with Pablo Abonia and others at Cincinnati, come up with an algorithm that can help us with identifying, how to best quantify. We have a differential diagnosis, suspicion for mast cell associated disease, maybe stain with CD117, and depending on the pattern we see, maybe restain with tryptase, and then potentially, even if we're really unsure if it's a mast cell tumor, think about staining for something like CD25 or CD2. Moving beyond that, I think definitions are really, really, really important. And that term mast cell becomes very nebulous. What is it really referring to? Well, you can see here a really nice table from a review that I put together recently with Chem Aiken and Marcus Moore and a bunch of others, looking at the different types of mast cell problems. So mastocytosis, like mast cell tumors, essentially, or mast cell activation syndrome. You may not have a ton of mast cells. Your just mast cells are more twitchier. Or anaphylaxis, the mast cell is going to get engaged, release a lot of things like histamine that's going to cause things like hives or facial swelling or breathing issues. There's localized mast cell activation, so you may get a hive. And of course, there's even T cell associated mast cell activation, and EGIDs are a factor here. And of course, this is where mast cells probably are playing a role within the context of the EGIDs. Mast cells are really increased in EOE and other EGIDs. You can see a number of reports here, and in basically all cases, you'll find more mast cells regardless of how you stain in EGIDs, even in eosinophilic colitis. So what's the relationship of mast cells to abnormalities in EGIDs? And we'll focus mostly on EOE here. You can see a very good correlation with eosinophils, at least in kids. If we did the same experiment in adults, it might not be so good, at least based on a paper that Evan Dellin published. That one, maybe it's cohort specific, we don't know. But certainly there seems to be somewhat of a correlation, at least in children. Now, when we look more closely under the microscope, we pick out those histologic findings. There's one finding in particular that seems to have the best relationship, and that's the thing called basal zone hyperplasia. So that's as the tissue is turning over, gets thicker, and looks more immature. Now it's the younger, more rounded cells and not the flatter cells that look more like skin. Though the degree to which that basal zone hyperplasia is present is related, it seems, to the number of mast cells, although eosinophils seem to have an even better relationship. And maybe if we put them all together, it's even better than that. So we're really still trying to understand, do we even need to quantify them? What if I just see basal zone hyperplasia? Maybe it tells me there probably are a lot of mast cells. We've also looked at the endoscopic reference score, or EREFS. This is characterizing the critical findings associated with EOE. Again, this is a study of children, so not a lot of rings present, but you can see actually mast cells in this particular study had a better correlation with the EREFS score than did the eosinophil, and maybe it's comparable when we put them together, or even possibly better. So again, is there value potentially in quantifying them, or maybe we just need to be really good at measuring the EREFS, because that'll tell us the extent to which maybe there's still ongoing mast cell inflammation. And again, trying to define what really is remission in the end ultimately becomes important. We've also looked at symptoms. There were absolutely no symptoms associated with the eosinophils, but interestingly, nausea, vomiting, and pain seem to be associated with the mast cell count. And particularly interesting, pain has been already observed to be related in some work by Sim and Zhang. And now maybe potentially nausea, vomiting is more of a novel finding. So certainly very, very interesting, a potential relationship between the mast cell count and the extent to which nausea, vomiting is being reported on a symptom survey. Now, in eosinophilic gastritis and duodenitis, there does not seem to be that significant relationship. So really minimal correlation. You can see a mild correlation in the duodenum, no correlation in the stomach. And when they looked at symptoms in this paper, this is work by Evan Dellin, you don't see any correlation with symptoms or endoscopic findings. So really the story is still very much untold in eosinophilic gastritis. And we need to look even more at children and understand what's going on there as well, because again, it may not be the same disease between kids and adults. So how do mast cells change with treatment? I think this is really important. And by and large, they're going to go down. So in general, when we treat a patient, you're going to see a reduction in the number of mast cells. You can see it, especially in patients that are eosinophil responders. They have low eosinophils after treatment. In general, their mast cells are going to go down. And even we're showing over here in the lower right, patients that weren't eosinophilic responders to milk elimination diet, but they even had a reduction in mast cells. And it may be somewhat therapy specific, as I'll show you in just a minute. Now, there can be elevations in the mast cells that persist even with there being low numbers of eosinophils. And as I showed you before, if the endoscopic abnormalities or the basal zone hyperplasia is persisting, and that can persist even when the eosinophils are low, you may get a higher number of mast cells. And what I'm showing you here is that patients that had abnormal endoscopic reference score, and even those that were symptomatic, seem to have higher mast cells. We've replicated that finding now in a similar study comparing now active EOE to patients in remission with findings present or patients with total remission. You can see that intermediate phenotype of patients with a higher number of mast cells, and even that's definitely a higher number clearly than controls, than healthy controls. And again, that correlation with basal zone hyperplasia. So it really appears that mast cells probably are a good biomarker of when there's endoscopic and or histologic abnormalities, and ultimately a reason why our target potentially should be complete histologic and endoscopic remission. A good goal, of course, not always achievable in every patient. Well, we really understand what could actually be triggering the mast cell. And we had this really nice study where patients were taken off of milk, soy, wheat, and eggs. Those that were in remission went on to reintroduce foods sequentially. Every time a food trigger showed up, they had to take the food out and then get rescoped. They would then start reintroducing triggers again. And this allowed us to identify various triggers. Well, of course, the mast cells nicely responded to the 4-food elimination diet with a significant reduction in both the lower and the upper esophagus. And interestingly, when we looked at the foods that seemed to trigger an increase in mast cells when there was an increase in eosinophils, so we know the food is triggering aspects of their disease, it was only the wheat and really only the milk. The milks clearly did it to the largest extent. When we looked at food-triggered symptoms, which is the what you're seeing on the right here, again, only the milk, where milk is driving an increase in symptoms, we're now seeing mast cells go up. So is it food-driven? Again, a very important question. We don't know the answer to this, but this study certainly raises important questions about the role that mast cells potentially are playing and the triggers that are ultimately driving them. There's really limited studies on mast cell changes with treatment. This was the drug AK002, which did not succeed in its phase 3 trial, but at least in phase 2 trials, there was a reduction in mast cell counts, 17% with AK002 compared to a 17% increase in placebo. Now with eosinophil targeted therapy benralizumab, no changes in either stomach or duodenal mast cells has been seen. So clearly there needs to be targeted therapy, whether it's mast cell targeted or just Th2 targeted or type 2 inflammatory signaling targeted, still remains to be seen. So a lot of work to understand gastritis, duodenitis, and certainly very little work done on colitis. Well, how about activation? Very important question. There's a whole lot of signals that can potentially drive mast cell activation. You can see all these different receptors, and when many of those receptors get engaged, you get all sorts of molecules, some of which are preformed, things like histamine, tryptase, chymase, some of which get synthesized pretty rapidly that are lipid mediators, leukotrienes, and some of which are more cell-cell communicators like chemokines and cytokines. Now, there's also an increase in mast cell activation that you can detect in the tissue. And one of the ways that we'll look at that is with flow cytometry. With flow cytometry, we take a biopsy, break it into individual single cells, stain it for things that appear on the surface of the cell, and then run it through a specialized machine that has lasers that pick up the fluorescence. And when we do so, we can detect whether there's more of something or not. You can see in EOE patients increase in the number of mast cells present by flow cytometry in the esophagus in this paper by Brad Youngblood, as well as an increase in 2 markers of activation, CD63 and CD107A. Now, interestingly, these markers do denote different degrees to which the mast cells have been sort of recently or more long-term activated. CD63 takes a lot longer to go away on the surface of the mast cell. And so it appears at least that there's evidence of chronic mast cell activation occurring in the tissue of the patients. And I apologize, this last slide was labeled EOG. This is the EOE patients. Here's the EOG patients. They also have an increase in the number of mast cells present in the stomach. And again, a very similar finding with that increase in the CD63 and CD107A present on the surface of their mast cells, demonstrating that there indeed are chronically active mast cells present. Again, do we target those things directly or indirectly with a drug like dupilumab? I think is an important question. In addition, Mark Rothenberg's lab has really nicely shown us with single-cell RNA-seq that there are multiple types of mast cells present. He identified resident mast cells. These are mast cells that normally live in the esophagus, persistent mast cells. These mast cells appear to persist even despite treatment, and then transient mast cells that appear to be present only during active disease. Now, interestingly, he looked very closely at activation patterns, and what I want you to appreciate is the one on the right, that these persistent mast cells seem to have a stable activation period even though treatment is ongoing. So despite the fact that the patients are in remission, they're still poised to respond. So they're in a poised state to become activated now. And I think this is an important consideration in terms of the fact that the remission state is really a state that's prepared to become reactivated and emphasizes really the need for chronic therapy to control it. Well, mast cells release a variety of molecules with many different effects on the GI tract. You can see a schematic from a review that I published showing things like TGF-beta, tryptase kinase, IL-13, and their impacts on things like muscle, fibroblasts, epithelial cells, as well as nerve cells. And people have done, labs have done models to look at the impact of mast cell activation, for instance, on the tissue. In this particular study by Kluskins et al., what they do is they grew mast cells in the lab, incubated them in liquid media underneath epithelial cells, which are structural cells that they grew on a membrane. They grew them in such a way to sort of replicate a 2D, 3D version of the esophagus, and then they activated those mast cells. And when they did so, what they saw was a reduction in the transepithelial electrical resistance, or TEER. And as the resistance goes down, that implies that there's barrier loss. So when mast cells get activated, they can disrupt the barrier. Now things can more easily leak into the esophagus, and mast cell activation appears to be a potential trigger. They identified this compound called oncostatin M, and oncostatin M by itself was able to reduce the resistance and increase the permeability of the esophagus tissue. So a lot of interesting things capable from mast cell activation. There's likely other molecules that are driving the effects that are seen in the esophagus, not just oncostatin M. In addition, the Rothenberg lab has identified that mast cells can express IL-13. These IL-13 mast cells, you can see here in the lamina propria, are increased in the patients with active EOE in the epithelium. So it appears that these mast cells are probably migrating from the lamina propria, it's deeper layers of the tissue, into the epithelial region, and then that's probably where they're causing a lot of injury or changes to the tissue that may be part of the pathogenesis of EOE. In addition, Simon Zhang has looked at the association of chest pain with mast cells. As I mentioned, she found that patients with higher numbers of mast cells were more likely to experience chest pain. And interestingly, she found two genes, CPA3 and HPGDS, were highly correlated with TRPV1, which is a nerve marker. And she showed that mast cells were in close proximity to TRPV1 positive nerves. And there's been other literature to look at the impact of mast cells directly activating nerves themselves. And so there may be certainly a potential for mast cells to drive certain symptoms. And I already showed you that in children, there appears to be a correlation between the mast cell number as well as certain symptoms. In addition, TGF-beta can be produced by mast cells, and particularly mast cells found in the smooth muscle. There's increased numbers of mast cells expressing TGF-beta, and this TGF-beta is capable of causing muscle contractility. So you can see here an image on the right of muscle cells that have been treated with TGF-beta, and contraction is occurring over time as there's a reduced amount of area. In addition, the Rothenberg lab has assessed in an animal model what it means for a mouse to be deficient in mast cells using an aspergillus-driven model of EOE. And what they found is the increase in muscle thickness that's normally occurs with the EOE model is lost. So it really implies that mast cells probably have a very important role in remodeling. They're probably contributing either to the fibrosis or the contractility, the smooth muscle contractility, or both. Excuse me. And lastly, I'm going to show you some data hot off the presses. So we've been doing a study to try to understand POTS and connective tissue disease, particularly in EOE patients. So the patients are consented into a prospective study where they complete a survey called Compass 31 that captures different elements of symptoms associated with POTS. So things, particularly one of the classic POTS symptoms you may be familiar with is dizziness with position changes, and that falls into the category of orthostatic. But many of these patients will have a variety of symptoms that are all captured on this particular survey. But what you can see is that when we looked at stomach and duodenal mast cells, we did not see any correlation with symptoms. In addition, we did a hypermobility survey on the patients, and we did not see any differences in stomach or duodenal mast cells between patients based on the status of their hypermobility. We did see slight differences based on whether your EOE was active or in remission. But interestingly, it actually seemed like the remission patients might even have slightly higher duodenal mast cells. So still a work in progress. Of course, we're looking at this from a lot of other aspects, but I certainly thought this would be extremely interesting in the context of mast cells, and always a huge question of their relationship to POTS and connective tissue disorder. I don't think this rules out that there's a connection at all, but certainly in this cohort where there was evidence of POTS, at least in a small portion of the patients, we didn't see any differences associated with the mast cell. Lastly, I'm really excited about emerging medications that have the ability to target mast cells, and I mentioned Celldex, and they're working on a drug, barzolvolimab, and that drug targets CD117, and you can see here with one dose or a remarkable reduction in tryptase levels, as well as significant impairment of the ability to degranulate mast cells by beta-hexosaminidase. So we'll see what happens when EOE patients get this drug. I'm really hopeful to see, if they feel better. I think it would be really telling, what happens and the potential impact of targeting mast cells in therapy. And so what we do know, well, we know that mast cells are elevated in EGIDs and density and activation. EOE treatment seems to reduce mast cell density and activation. However, ongoing endoscopic abnormalities like edema and furrows or histologic abnormalities like basal zone hyperplasia can be associated with increased mast cell density and activation. Mast cells likely contribute to barrier dysfunction, remodeling, and symptoms. But what we don't know is eradication of mast cells or their activation effective therapy for EGD? For EGIDs. If we directly target the mast cell, will that be a good idea for the patient? Is normalization of mast cell density in EGIDs necessary to prevent complications? Do I have to get the mast cells to be low to limit the development of a stricture? And then what's ultimately driving the mast cell activation? And I'm sure there's a multitude of factors of things that are driving it. And I think more to come on this, as many labs certainly are working on trying to answer this important question. A nice picture of Lurie Children's Hospital. Certainly want to thank Cured for the opportunity to talk to you. No doubt for the support of our research going on at Lurie Children's and the opportunities I've had to collaborate with some of you probably on this call. And of course, I don't know if we're going to take questions right away, but I'm always happy to answer questions.
Thank you so much. That was so interesting. And we do have questions. You mentioned staining issues for mast cell. Do they typically look for them in biopsies during a scope, or is it something we should ask for?
Yeah, it's not routine staining. It can cost extra money. So, even for myself, it's not routine to be staining for mast cells. There has to be a fairly unique circumstance where I really am having a hard time understanding what's going on with the patient. And I will say this, even when I've stained for mast cells, I see there's high mast cells. I know something's not right with the patient. It's very hard to convince the insurance company to pay for an additional therapy.
The next question is, have you ever heard of treating mast cell activation with cromolyn oral solution before meals, and could cromolyn possibly help EOE?
Yeah, there's been a nice study of cromolyn. There was a numerical improvement in symptoms. There was no significant improvement in the eosinophils, so there's no clear evidence that it is a legitimate treatment that should be considered, although an animal model has suggested there could be some benefits. And whether it's a dose-related issue, I don't think we really have a good sense, but I wouldn't recommend it. You have to take it many times a day at this point. As far as, treatment of other symptoms, empirically, there, of course, are going to be a lot of patients that will tell you that they got better with cromolyn. I definitely have not seen a particular pattern where I can pick out which patients, if I were to start cromolyn, would get better. But it certainly, can be something to consider, if you can keep up with the regular dosing and, and you're not having any potential side effects.
Have you seen mold as a trigger that caused mast cell disease?
I personally haven't. I wouldn't be surprised if that existed, but identifying mold as a trigger of a GI inflammatory process is really, really challenging. So while I'm sure there's probably mold-triggered allergic rhinitis and mast cells are clearly involved, it's not necessarily the primary process. That's probably mostly IgE driven. And in that case, the problem is really the IgE. More than it is necessarily the mast cell. That's the ultimate problem. And I think, allergy shots or antihistamines or SLID or things like that end up being, reasonable therapies to consider. And talk to your allergist, because I'm just a GI doc.
Is mast cell density in EGID higher in males?
We have not seen anything like that yet. I wouldn't be shocked if a cohort could be defined that found it, but repeating something like that where it was clear across multiple cohorts, whether it's true of young kids, it does seem like mast cells might increase a little bit with age. There have definitely been some studies that have suggested that, but there's really not good evidence on the relationship of specific demographics to mast cells yet, and I wouldn't hang my hat on any particular detail there.
Are there any other questions? Dr. Klion is still on the call, Dr. Abonia, for Dr. Wechsler or Dr. Gabryszewski.
We have another one. Do allergy medications help with mast cells for children with mast cell urticaria on the skin? Long-term usage of allergy medication complications.
I think, Dr. Abonia, that might be a good one for you.
Yes, as far as allergy medications are concerned, we use them very, very frequently in patients who are having problems with hives. As I mentioned earlier, hives are pretty common in patients who have EOE or EGID type problems. So using antihistamines happens all the time. Dupilumab of the current therapies is unique in that it actually has impacts directly on the esophagitis, and is also indicated for the treatment of problems of hives. So that ends up being a medication I'm considered using, especially in patients who are having a lot of problems as far as their hives are concerned. And sometimes, quite frankly, those patients have bigger problems with their hives than their EOE kind of issues. So they'll be happier with that. But as far as control and the safety of the medications, Zyrtec, Allegra, or cetirizine, fexofenadine are commonly used for these kind of problems that can be used all the time and are over the counter for that matter.
Any evidence of early dementia after a very long use of PPI for EOE?
Yeah, there was a study, I think it was about 7 or 8 years ago or something now, maybe even longer, that suggested that was true. And a subsequent study has come out and essentially debunked that. So we do not think that PPIs are associated with EOE. I will even go so far as to say there was a recent study from 2025, 60,000 adults, and no clear association with bone mineral density loss. So really our understanding of side effects of PPIs, there probably are some. And I think, I'm always very much going to take a patient very seriously when they think there could be one. But in terms of like the thinking that there's a large number of side effects that are common with PPIs, I don't think we see it.
Can mast cell reactions trigger flares of comorbid conditions?
I don't think so, but Pablo, I'd probably want to ask your opinion on that one too. I mean, maybe you've seen something like that where you could sort of identify that answer better.
I mean, the thing that I run into most commonly would be concerns for mast cell activation syndrome, right? So basically a fundamental process where you're having swelling, itching, all the common things that you see that. I don't typically think of it as causing problems with asthma or seasonality or those things as a consequence of the flare. I typically think of that it's like, okay, I've got seasonal allergies, and the seasonal allergies have caused my mast cells to flare. I've had asthma, I've got a viral infection, and that's caused my asthma to flare and may also cause me problems with hives and things like that. Mast cells can easily be triggered by viral infections, and it's probably the most common cause of unknown problems with hives in pediatric patients.
Yeah, I think Pablo raises a really important point because it's always chicken or egg with mast cells. And so frequently they're just the effector. They're at the end of the stage and they're not at the beginning. And so targeting them frequently is not that effective as a primary way to treat a disease.
Have they noticed somewhat protective factors for IgE when using dupilumab for treating EoE?
Yes and no, as far as IgE is concerned. The way dupilumab works, it blocks the IL-4 receptor alpha, as mentioned by Dr. Gabryszewski. Sorry about that, Stan. And as a consequence, when you look at EoE, it's actually, when you look at the IL-4 receptor, it's actually used by two different cytokines. One's called IL-4, the other one's called IL-13. As far as IL-13 is concerned, it's actually the predominant one that's involved as far as EoE is concerned. If I just take IL-13 and sprinkle it on the surface of the esophagus, it will start to look an awful lot like esophagitis. So that's one of the reasons it got used for that. On the other hand, IL-4 is the penultimate thing that actually drives the presence of IgE protein. So if you want to have an IgE protein for cat, for example, you have an antibody to cat, it grabs onto the cat, antigens when it's nearby, brings it to the mast cell, makes you have stuffy nose kind of problems. You've got an allergy to milk, there's an antibody to milk, grabs on the milk, brings it to the mast cell, and causes it to have an allergic reaction. To have those levels of IL-4 in your bloodstream go higher, you have to have the IgE proteins in your bloodstream go higher, you have to have IL-4 there. So as you basically block it by using dupilumab, these IL-4 levels will go down, down, down over time. So as a consequence, you will watch all these things go down over time. So the tricky part about that is that you do run into a risk where you might end up in a situation where you have a test for peanut that looks normal, you do your food challenge, and you still have an allergic reaction. So that's one risk of that kind of problem. But it clearly can make things a whole lot better as far as hives are concerned. I have had many patients who've had simultaneous EoE and chronic urticaria and watched their hives go away with this kind of a problem. So it's probably a consequence of that reduction in IgE levels, and it's also probably a direct consequence of IL-4's impact on the mast cell. IL-4 will actually make a mast cell more likely to secrete things that it shouldn't be secreting as far as allergy type problems are concerned. Amy, you have a question?
You're on mute. Dr. Klion.
Okay, I got it. Now I'm off mute. So there's been a lot of talk about dupilumab, and I didn't bring it up in my talk because of the time, but I think it's worth being aware. I pointed out a number of cases of patients who seemed to have EGID, but turned out to have really a more systemic HES. We did a study, a retrospective study in literature review, looking at patients who have a history of high eosinophil counts, and showed that the risk of eosinophilia and eosinophilic complications with dupilumab was much higher in that group. And we saw some really significant complications. We had a patient with fluid around the lung that was eosinophilic, and we had a patient with a coronary artery dissection where that was due to eosinophilia. And so monotherapy with dupilumab in people with very high eosinophil counts at some point in the past can be unsafe. We're in the process of trying to sort out whether you can use dual therapies. And so we have a protocol running for patients on eosinophil lowering therapies who have persistent symptoms where we can add on dupilumab, and in that setting, keep the eosinophil count low and get the benefits of dupilumab. the big question is whether that will increase some of the side effects that were talked about before in terms of things like psoriasis and other autoimmune phenomenon. And that's not really being looked at very well in a systematic way.
Yeah, I would add to that too, that I've had even some patients where the eosinophilic gastritis, there was very severe remodeling going on, and it even seemed to have almost more of a Crohn's-like phenotype. And I totally agree with what Amy said, that it is not uncommon that monotherapy is ineffective. I have some patients where maybe I've put them on budesonide, or we've even tried JAK inhibitors as well, and I have a decent amount of success with several JAK inhibitors. That do seem to be effective at controlling inflammation, not just in the stomach, but potentially even in the colon as well. And so throughout the GI tract. And so I think, a lot of thought has to be given, to what's really the primary driving process. Just like Amy said, is it HES? Is it IBD? Is it actually just primary EOG or D?
Yeah. And we're always cautious as far as the eosinophilia is concerned. When starting these patients, we will go ahead and check CBC with differential before we use it. And we will also go ahead and typically check it once or twice after it actually gets started to make sure that we're not having a gross increase in the eosinophilia. And we also have the same concern for patients who have very high eosinophil counts beforehand.
Thank you. Where else do you get to listen to this great conversation except for a Cured conference? We feel so lucky to have you here. The next question is, why do you think that dupilumab would work to control EOG for 2 years, but then suddenly stop while continuing to control EOE, EO's asthma, cold urticaria, and eczema, and also prevent anaphylaxis allergies, but not control the EOG?
Yeah, we probably can all weigh in on this one, but Amy, why don't you take the first stab at it?
So we're actually doing a study to explore just that kind of thing. So we know that some patients who have eosinophilic gastritis will have damage done to the stomach, the same way that patients with EOE can have damage done to the esophagus. And some of that damage can cause the stomach not to work as well as it should. That may not get better with the therapy. And so when you treat and people get better, then sometimes that can still progress. In the stomach, it's called gastroparesis. There are actually 3 sites, Chicago, Utah, and us, that are looking at exactly that. So at patients with persistent symptoms despite apparent treatment of their condition, to see whether a stomach function problem is what's causing it.
Yeah, I would second that as well. And we've done at our center even pyloric endoflip. And there are definitely in a significant number of patients where we've looked, and not a huge number at least, low distensibilities in these patients. So there may be a multitude of mechanisms. Eosinophilic diseases are typically throughout the thickness of the tissue. They can cause remodeling. Certainly they may impact both sensory and motor function. Just like Amy said, why you lose effective therapy can be for a variety of reasons. I totally agree with that.
The next question, could we look at mast cell markers in a biopsy instead of trying to stain the cells? Maybe surface or granule markers?
Yeah, I mean, I think that, the question at the end of the day is which is the magic marker, and what's that marker going to tell you? And, ultimately these things, generally from a clinical standpoint come down to cost. So as much as we, we'll look at them in the lab and create a finding that seems interesting, the real question is can we get a payer to cover the cost of doing the test? And, whether it's, grinding up a biopsy and looking at how much activation of the mast cell there is, or measuring, how much something comes out of a biopsy, and that's a measure of a mast cell activation, or like you said, measuring another molecule at a gene level or a molecular level. The paper that I published with Chem Aiken and Marcus Mora, that's exactly what we talked about. What's the perfect test? Is it a gene test, a protein test, a flow cytometry test? And the reality is we truly do need better tests clinically, especially because there's a real significant limitation of a number of our tests, and particularly as it relates to underlying genetic conditions and how they might even influence those kinds of things as well. I'm sure, Amy can probably weigh in on, Pablo can weigh in on that as well.
I think you answered fine.
Yeah.
Can itchiness inside your head after eating food, even foods that you ate before on a regular basis, could that be related to mast cell activation?
Yes, in a sense. One of the more common problems that you run into is something called oral allergy syndrome, in which patients are sensitized to things like tree pollens and things of that nature, and also have a sensitivity to things like apples. So what ends up happening is they get stuffy nose during the springtime, but they also get an itchy mouth whenever they bite into a fresh apple. So it's an itchy sensation that's caused by a mild allergic reaction because it's much closely more targeting the tree pollen as opposed to the apple skin that's causing the issue with the itchy mouth. In those patients, for example, they'll get the itchy mouth when they bite into the apple, but the moment they go ahead and peel the apple, there's no problem, or bake the apple, there's no problem. So that's what I would suspect in that kind of a situation. It's notorious for the lips, mouth, and also a little bit into the nose.
When initially starting Dupixent, why does blood eosinophils increase?
So I can
I-
take this one.
Oh, go ahead.
Oh, that's all right. Oh, or you can answer if you want, but
Yeah, no problem.
anyway, so dupilumab action decreases eotaxin. You have to think about eosinophils. Andy Wardlaw used to talk about eosinophils like on a seesaw. So you have eosinophils being made in the bone marrow. They go into the blood for a short period of time, and then they go into the tissues. What dupilumab does is it blocks them from being attracted to go into the tissues, but it doesn't have any effect on the bone marrow production of eosinophils. So if you have the bone marrow making them, they're going into the blood and they're not getting sucked into the tissues. What happens? They go up in the blood. We think that's why patients who have hypereosinophilic syndrome or very high eosinophil counts, where the bone marrow is making lots and lots of eosinophils, are more at risk for the very high blood levels following dupilumab.
MTHFR gene mutation related at all to mast cells disease?
As far as I know, it is not. It's basically used in folic acid metabolism. So it's actually involved in folic acid and vitamin B12 kind of things going on. MTHFR mutations are actually extremely common. I think it's like 16% of the United States population, something into that. Well, indeed, I actually have a couple of them myself. And it's the kind of thing that is, it's probably like a disease modifier where it can make some things worse, but it's not necessarily a thing that will cause you to have the disease in and of itself.
Thank you. I know it's getting late. If you have to go, any of the doctors, we totally understand. But questions are still coming in. This is a really big treat for the patient community. It's up to you if you're able to stay on and answer a few more questions. Okay. Shay, you want to get the next one?
Sorry, I'm on mute. Related to fire, what possible cellular reaction to that? Could it be totally wrong about this? More immediate reaction with food EOE.
Yeah, that's a great question. So the short answer is that we don't currently know. That the rapid response, the food-induced rapid response to the esophagus, which is typically can be associated with like beer, fruits. There's all sorts of foods that have been associated with it. The cellular cause is currently unknown. We actually did we were working on a study with Dr. Hirano a few years ago, and he had identified a bunch of the patients that he was taking care of that had fire and some that didn't, and we looked in to see whether there were differences in mast cells or differences in IgE, and we didn't see any differences. And so the long and the short of it at this point is we don't have evidence it's the mast cell, at least, so probably can cross that one off. But you know, at the end of the day, a lot more work is needing to be done because it's really ultimately prospective studies that are needed to define something like fire. You have to take a patient probably as they're having a fire symptom and really actively interrogate them, because these symptoms are very intermediate and whatever the cellular finding is may be very transient. So I don't think we have really any sense of it at this point.
Is there a relationship of histamine food and EOE?
Histamine is actually present in a large variety of foods. Probably the most notorious would be things like bad fish, or fish that's gone bad, that is. And you can end up in a situation where, in that particular case, fish is like rotting on the table for a while. You eat it, and then you have a huge amount of histamine released into your body as a consequence. In addition, smoked foods can also have a lot of histamine in it. Sure, it can cause problems with flushing, but it's not a direct thing that I can think is actually directly related as far as EOE is concerned.
Can OIT for food allergies be a precursor for developing EOE, or does data indicate that EOE is present before OIT treatment starts and it triggers its symptoms?
I can tackle this. So in the literature, it's been described that about 5% of children at OIT might develop EOE. At our center, we've seen much lower rates in our practice. But yes, it's a potential side effect of OIT to develop EOE. Now, could you potentially have IgE-mediated food allergy and not know that you have EOE, and then it becomes unmasked after starting OIT? Certainly, sometimes it's not entirely clear if it came before or after.
And I would add to that too, that Ben Wright did a really nice study where they looked at patients on OIT and saw eosinophilia was actually quite common. And in some patients, it actually went away over time. So the extent to which the chronic disease EOE, where we have to now give new treatments, gets truly unmasked. I mean, I think we really don't have a good sense of how much of it, really starts before and was even present there. As many times as I scope food allergy patients with allergists worrying about it, I oftentimes don't find it.
Yeah. Our experience, we've got a fairly sizable oral immunotherapy program going on here. And what oral immunotherapy is meant to do is make a patient who's got a food allergy to like peanut or something to that effect, and make you less sensitive to in general. And what we ended up finding, well, not through any sort of research, maybe, but our experience so far has been that most of the patients who end up with EOE have pre-existing problems that are very, very, very consistent with it. They had dysphagia, they had vomiting, all those things going on beforehand. And you oftentimes find a family member who's got EOE that says, okay, yeah, that's not too surprising that that's happening. Even with patients who do have evidence of EOE as a consequence of their OIT, we're basically at the mindset that we can continue doing OIT so long as we control your EOE through some other means, whether it's the swallowed steroid therapies, the proton pump inhibitors, or the use of dupilumab. So long as it's controlled by some other means, there's no reason not to have the benefit of control of EOE while also avoiding the severe consequences of a severe allergic reaction related to whatever food that you're dealing with, so long as we actually do OIT for that food.
So you're saying if a patient has EOE, you would still do the OIT?
Yeah, we do that fairly frequently nowadays. And we do that for patients who are on one of the other effective therapies so long as it's able to control their EOE. There's no reason not to, because you could end up in a situation where now you have to seclude yourself as a consequence of your emergency allergic reaction that could potentially send you to the emergency room, as opposed to a chronic problem that you can potentially manage with a medication. So we will go ahead and do that nowadays.
Well, thank you so much. That looks like the end of the questions. Thank you all for being here, especially our speakers. We're grateful to have you working on our disease, as well as taking time out of your very busy schedules to help educate our patients. And thank you to the patients for joining us. And we will see you tomorrow night for the last night of our conference. And there will still be another night of National Eosinophilic Awareness Week, but our conference will end after tomorrow. Thank you all for being here. And remember, you can follow us on Facebook and Twitter, and also Instagram. Everybody have a really good night.